Hello everyone, I'm Arvind Reddy. I'd like to introduce our panel today. I'm excited about our panel because we have a very distinguished set of panelists who represent different perspectives. We have experts from representing the patients, clinicians, researchers, technologists, and the healthcare system. And with that, I'd like to introduce our panel members. First, we'll start with Professor Jayson Burke, who is Systems VP and Chief Analytics Officer at the UNC Healthcare System. Dr. Michael Kosorok, W.R. Keenan Jr. Distinguished Professor and Chair of Biostatistics and Professor of Statistics and Operations Research. Mr. Saul Amezquita, Senior Patient Experience Consultant, Atrium Health. And as we all know, Dr. Terrence.
The story is still as it was half an hour ago.
Dr. Terrence Holt, who is the Assistant Professor, Division of Geriatric Medicine and Assistant Professor, Department of Social Medicine and Internal Medicine.
I've been demoted.
So we'll be directing specific questions to each panel member, and once the primary panel member answers each question, other panel members can chime in and share their thoughts on it. So we'll start with Saul. So according to you, what impact could new technologies have on informed consent either in healthcare or research setting?
Sure. So our work is in health literacy, which is trying to make sure that patients can understand their care so they can get better. That's ultimately the goal, so they can get better. So I think that the positive and negative side of this is, the positive side is new technologies can make informed consent, which is make sure that patients understand, can make interactive consent forms, can make education in a way that is simple with images and graphics. The negative side of it is that we have to, that could take the place of the conversation that is supposed to happen between the provider and the patient, which is ultimately, per providers and our legal team, that is the most important piece. So I think new technologies have a lot of good things that we can use it for, but we have to make sure that it doesn't get rid of that human element.
So Dr. Jayson, would you like to, Professor Burke, would you like to share your thoughts on that?
So I agree. I would also point out that there are areas where emerging technologies could be helping us that we don't see in widespread use today. So if you think about patient consent, for example, a patient can consent and revoke consent. They can do that over periods of time. They can do it over parts of their data or all of their data. And being able to manage that pedigree, that life cycle of who granted what when, and is it still current, and how do you preserve that, is a very, very challenging issue from a technology and a management perspective, and one that as an industry we haven't really got our heads around how best to manage that. We're usually pretty good at knowing what the most recent answer was. But we're not very good at the granularity and the history and the management associated with that.
Dr. Kosorok and Dr. Holt, would you like to share any thoughts on that?
Well, actually, this is one that I don't have a lot to say because I think the two of them really addressed it very well, but I can see it as a challenge. And you're right, my voice is super quiet, so thank you for this. And all you didn't hear was that I said I didn't have much to add.
All right.
I think it's important to remember that informed consent is an ideal rather than something we actually achieve. It's impossible to explain to somebody, certainly not in any form, whether it's interactive or on paper, what bone marrow ablation is going to feel like three weeks later. You just can't. And also, it's important to remember that a lot of our patients show up here not of their own free will. Their consent to treatment is coerced, not by us, but by their illness. And I think we just need to respect that fact. I don't think there's an excuse to not care about informed consent. It's vitally important. But it's a matter of of understanding that just because you've gotten that signature on a form, you're still dealing with somebody who's critically dependent on you to just to stay in communication about what's going on. And if nothing else, to sympathize with the situation. I mean, it's not licensed to do anything. It's at best permission to step carefully.
Can I ask a question?
Yeah, sure. Please go
I'd
ahead.
like to ask a question to Saul about what you guys are doing. So one of the things that I see, if a clinician or staff person has to explain the same thing over and over every day, they tend to lose enthusiasm. It's just an automatic thing. And you can tell when someone said this 10,000 times, right? It doesn't necessarily impart understanding. I was curious how hard or how successful it has been to get staff to be aware of what the technology, the informed consent can do and how they can augment that. In other words, does it get them to a different type of question, a different level of understanding beyond just a rote, I've got to get this information to you?
So I would say that we have not completely solved this. One of the biggest things that we are doing, and I'm here with Hope, my colleague, and we do this for our system, is we want to change a culture that is focused on helping patients to understand, or at least to be engaged in their care. So there are things beyond the fatigue that there are programs, like for example, there was a program that Hope was involved in called Curo, which was provider specific, that helped them to have, and again, you'll hear this often, the human element, to ease burnout, ease that fatigue. So I think that there's different things that we try to do, and we try to promote within our context how they can just not check the box, but we haven't solved that problem, because when you're talking about a system as large as us, we have over 60,000 employees. So trying to influence that, it's been a big undertaking at this point. I mean, we're rebuilding our structure for health literacy, but I think right now with all of the movement with trying to cut back on our budgets, combined with so you're having all these teammates that are losing their jobs. You have some that they're increasing pay, some aren't getting paid. You have consolidation of departments. So in the real world, you are, especially those who are in operations, you are extremely stressed. There was a department that just got disbanded. Some of them came over to yours, so now you have an extra 45 direct reports. And so to be able to maintain that level of heartfelt communication, passion, is very difficult. So I think that is one of the things that we as a healthcare system, and even in our country and in the world, that we have to find some balance with the things that are happening on the government level with healthcare. And I mean, this is issues that we struggle with all the time, but at the same time saying, okay, how can I still communicate with my patients? How can I still communicate with my teammates and my colleagues and keep that human element without, but again, we haven't completely solved it, but we are trying to find ways to make it still human.
Thank you, Saul. So moving on to our next question, Professor Burke. Individuals' right to privacy of their health data can come into conflict with worthy goals such as improved research understanding of a disease or better targeted healthcare interventions. How do you see these tensions playing out in your field, and how do you think researchers and healthcare providers can best navigate them?
Yeah, well, I think today we're navigating it reasonably crudely, meaning that we ask patients for consent to use their health information. Of course, we definitely needed to treat them. We also prefer that they allow us to use it in an anonymized way for research things. Usually the person that is asking for that consent may not be fully informed about how it might be used for research. And usually the patient isn't well informed about what risks might be associated with it. And so I would say we're young as an industry and trying to figure some of this out. Now bear in mind, a part of that youthfulness is a reflection of the fact that prior to the Obama administration, only 15% of the industry was on electronic medical records. And so that risk looks considerably different if it's a paper chart versus where we are today, where over 90% of the industry is on electronic medical records. And so there's a whole series of issues and responsibilities that come with that transition. And certainly in my field, in advanced analytics and data sciences and artificial intelligence, I think the biggest issues that we face are not the things we know, it's the things we don't know. It's the things that we haven't encountered before because we're new at this. This is, as an industry, we're just growing into becoming what many would consider to be a true data-driven industry.
Dr. Kosorok, would you like to add any thoughts on it?
Yeah, so one of the things I think would help, because we really do want to have access to this data for benefiting that patient as well as other patients, if we can be vigilant about how we preserve their anonymity and safety, and they see that vigilance and are convinced of it, that can increase our chances of getting to use that data for being responsible, and the patients know it. So I think that the positive side of this is by being vigilant, we have a greater chance of patients being willing to help us, and then consequently, we can help them more with the technological advances.
Thank you, Dr. Kosorok. Dr. Holt, would you like to add any thoughts onto it?
Well, you know, I'm always interested in when we choose to talk about problems in terms of individual agency, like how a resident handles the process of obtaining consent. And when we talk about structures, like before the Obama administration, 15% and 90%. There was a great piece by Atul Gawande in the New Yorker a couple of weeks ago about how the EMR, how the universal switch to really criminally wretched pieces of software like Epic have contributed to physician burnout. I mean, it's a huge problem. And yet, it tends to get viewed, at least within organizations, as a problem of individual agents. We need to train these people better or whatever. Whereas actually the problem is it's a structure that doesn't work. But the structure is expensive, the structure is stuck, we can't change it, so we're left in a dysfunctional relationship in which, in the case of this example, individual physicians wind up burning out because they're like rats in a maze where all they get is shocked. I think if we were able to think larger in more structural terms and spend less time thinking of individual agency rather than maybe effects on individuals, I think maybe we'd have more success in dealing with this. But we tend to start blaming individuals when we're stuck with a structure that we're too deeply invested in to change. And that just doesn't help anybody out.
Thank you, Dr. Holt. Our next question to Dr. Kosorok. Dr. Kosorok, how do you believe emerging technologies may impact the healthcare workforce? And what ethical considerations should companies and researchers keep in mind as they develop technologies that may disrupt the existing workforce?
So I think this is a really complicated, multi-layered question. I think there are a lot of ways this can affect the healthcare workforce. But I want to just sort of, to answer this question, maybe I could talk about one emerging technology that I think is going to play a very large role as it gets better and better. And this is AI-based decision support. That can be in deciding how to treat a patient or what to do during a surgery, or even how to manage the admissions process so that there's an efficient route for the patient to go, so that it's relatively painless for everybody involved. And even in terms of guiding policies at a clinic or a center or a larger institution. But as we become more involved in that sort of thing, and that becomes more part of what we do, which I certainly hope is what we work towards, there are many, many changes that can take place. One is the kind of interactions we'll have with this technology will affect the kind of training we need for clinicians and others who work in the healthcare field. and that will be a big thing. The effect that might have on how and when a human is in the loop, it's possible that if we're not careful, we might take too many humans out of the loop and have terrible things happen and not be aware of it. I think that's more of a science fiction issue. I think people are so cautious about AI, it's more of a overcautious, I think, than that being. But nevertheless, it's a possibility that we have to be aware of. And so training has to be different. Potentially there'll be challenges with people who are currently employed who need to be retrained. This happens with, historically, whenever there are technological and other kinds of advances, so it's not like society hasn't dealt with this before, but it's a very real one. And it could be that the very AI tools we develop can actually help us with that. But one of the things I want to point out is it's very important for us to remember and know when and how a human needs to be in the loop of the decision process. Of course, the most important one is the patient. But otherwise, it's also important for I imagine that we'll get better at making decisions about which treatments and which timing of treatments and which interventions are likely to benefit which individuals. But the entire healthcare package is more than just deciding what to do. It's other aspects of care. And so we'll have to manage that change because that will be a culture shift. And I think it's starting to emerge, but that's something that I think is going to be realistically a part. It is here and there a little bit, but I think it will be a bigger part in the next several years, 5 years maybe. Another issue that I think is perhaps related to that this may be a little bit tangential, but it's still something that keeps me up at night. That is that as we get really good at decision support, there is a possibility that bad actors will take that same technology and use it to harm entire healthcare systems and individuals, even outside of the healthcare system, use it to directly target people and cause inflict harm. This is something that I hadn't thought of until a colleague of mine had mentioned it to me, and then I started sleeping a little bit less. But I feel that, and there's no way to, that's always true in technology. Bad actors can really take it. We can list some recent examples of this. But I do feel that one of the things that can be done, and I know this is again thinking way ahead here and a little bit tangentially, but it was something that terrified me, so I thought I would share my ideas with you. We could think about this and actually be proactive in making sure that we are aware of the security issues, that these can come into bad actors' hands, and not be naive about that possibility. That's always been the case with technology, but I think we have to be especially vigilant. And I'm sure there are other important ethical issues I've neglected to mention, but some of the ones that percolate up.
Thank you, Dr. Kosorok. Professor Burke, would you like to add any thoughts on it?
Yeah, just agree with everything that was just said. And I think that the other thing that has increasingly come to my mind as we're thinking about workforces and how to navigate the changes that are happening here is that we often frame ethics-related training within science disciplines, but we probably increasingly need to be thinking about it in computer science and math disciplines as well, because those individuals need to have a greater sense of awareness of the potential downsides to the tools and capabilities that they're developing. And in many cases, that hasn't been a priority in terms of the way that those folks have been educated. So I do think there's an opportunity there as this becomes more of a forefront issue in healthcare that we make sure all of the different stakeholders in healthcare have a greater sensitivity and awareness to what we're talking about here today.
Could I just follow up on that? Because I think it's a really important point. Sorry, I have to pull this up a bit. I think that's a really important point, and I want to just expand that a little bit. I think that one of the things that I've been thinking about is actually a new discipline involving anticipation of, well, technology can get in the wrong hands, and try to anticipate and plan against it and work against it. I think that rather than just having it be a peripheral subject, it may be something we have to think a little bit harder about and actually spend some disciplinary effort thinking about.
You know, it's interesting. You're kind of at the youth of the EMR. I think it's really important. We're still very, very young in this whole business of the digital. And one consequence of that is we're just in love with it. Even if we hate it, that's a wrong love. But the assumption is usually that the digital is better than the analog form. I'm still not convinced that electronic entering of orders in the hospital is better than when we used to put them down on paper. When we switched to digital, we started encountering mistakes we'd never had before and didn't even know how to catch. Now, yeah, we got familiar with it, but we never think, how can we improve the analog system? Maybe the analog system, whatever problems there were with it, chiefly bad handwriting, which the unit clerk tended to catch, you know, we don't think about that. We just shift to the digital, and because we're much less familiar with it, we wind up in thickets we've never seen before and have to work our way out. Very, very painful. I'm not really a Luddite, I just like to play one metal.
Thank you, Dr. Holt. Moving on to our next question. Saul, according to you, are there any additional steps you believe your organization or others like it should take to address ethical issues around health technology or data?
So I think this goes along with the question. So healthcare, we have been traditionally very reactive instead of proactive. So we have to change that. We have to stop. We have to stop adding on so many things to what we're doing and just reacting to the things that are happening, and take a more mature approach. Because when you go to a counselor for your personal problems, they're going to tell you to stop reacting. So, you know, they're going to tell you, here's some action steps, here's what you got to do to take control of your life. You know, if you have a budget problem, same thing. You got to keep within that in the same way. Several years ago, I worked at the Living Cancer Institute there within our organization, and we did a lot of work with the Plaintree, which is a patient experience organization that's known internationally, and did a lot of retreats with staff. Some of them were all-day retreats off-site somewhere at a very non-sterile environment, and those were some of the most meaningful conversations that we had, because we talked about, again, going back to the human element piece, we talked about the human element, we talked about the patient stories, we talked about our stories, because we're all patients. So we talked about all these things that we connect with, that bring us back to our purpose, that how we lead and live by our values, and why are we doing what we're doing. And so then people could come and be refreshed. So I think that we have to invest. For example, we recently had our teammate engagement surveys done. So I don't know, did you guys have that? Did your organization have that recent? So that when I used to be a manager, that was like the worst thing, because I'm not a fan of the way the surveys are worded. And you can have, and we know of departments that had a very toxic environment, but yet they came out as a tier 1. So again, you know, because everyone wanted, because that was connected to their bonus, and everyone wanted to make sure. So again, you know, there's all that piece. But as a leader, and within, you know, like as we worked with Plaintree, and we worked with, you know, making sure we have that human element. We want to make sure that things are meaningful, that we come back to our purpose. We have to help our teams. We have to help our teams step outside of the snow globe of everything that's going on and view it. The snow doesn't stop. So we have to help them step outside of the snow globe to see the snow from a different perspective, so that they don't see it from the chaos of inside the snowstorm of the snow globe. And it's a huge task, and I'm not sure that there's exactly a way to measure it. But I believe that is the way that you're going to have more adherence to ethics, and because it becomes part of the greater narrative of your organization. And we have this by Facebook. And so, like, for example, talked about the privacy piece. The reason that now every time you go on a website, you have to press that, yes, I understand that you're, doing this and the cookies and all that jazz, is because someone was forced to have to make public and known that we are doing something with everybody. That's a different topic, but going back to that is, we should do more for the human element piece, and I think we don't, I think we discount how strong our emotions are connected to the work and the things that we're doing.
Thank you, sir. Dr. Holt, would you like to add any thoughts on that? So moving on to our next question, Professor Burke. As more and more data is collected about all facets of people's lives, we will likely gain new insights into the determinants of health not previously considered. How will this affect the job of healthcare providers, and how will it affect our understanding of health overall?
Who did that go to? Me? Okay. I didn't catch the name. I caught the question. So I think the place that we're finding ourselves in the field of trying to figure out how to apply analytics to healthcare is really very much centered around trade-offs. And the trade-offs are not simple. So let me just give you an example. So I'd like you to imagine that each of you was recently admitted to the hospital for some reason. And at the time of your discharge, whether you were admitted to UNC or Duke or Wake Med or someplace else, the EMR system is probably calculating a likelihood that you will be coming back to the hospital within the next 30 days. Should we tell you what that probability is? Should we explain to you why the probability is what it is? Maybe you could do something about it if you knew what it was. Now assume that 25% of the population in the room here today, all of you were recently admitted to the hospital. Assume 25% of you also suffered from an anxiety disorder. Now should we tell you? This is tough, right? This is really tough. These are not easy answers. And this is just one out of 100 analytical use cases that I can describe for you of the way that we're able to use health information. And some of it is uncomfortable for both the practitioner and the patient. These are real world issues that we're going to have to come to terms with. Certainly things like social determinants of health are one of the toughest areas to have that conversation around, because if you want me to tell you why you're at higher risk of readmission, I may have to tell you about how bad the place is that you live. And
should we tell them why we care about that 30-day interval?
That's a whole different question. I'm not sure that's an ethics question, but yeah. Yeah, I saw a hand raised and I was in the middle of a soapbox, so please ask me.
I think you bring up a really good point with but I think it stops short of something, okay? And I'm not saying this is easy to do, it's really hard to do. The analytics that we often see are not actionable, okay? So our responsibility in producing analytics to decision makers, whether that be the patient, the family, the provider, is that they be developed enough so that there's some actionability.
That's right.
And so many of us have been exposed throughout our careers to non-actionable analytics.
Right.
And it's the definition of frustration,
Yes.
right? And it's very, very counterproductive in ways you're going to think me.
Yes.
So I do think it's a responsibility of us really determining what's actionable and testing that actionability with controlled studies. Right? So I just wanted to kind of take that further step from my perspective. Not saying it's easy. I just want to make sure, it just seemed like it was a nuance of the question we could ask a little bit differently.
So I totally agree, and I'll just add on to one of the reasons that I picked that